Hello, everyone. Good morning. We're here on our next podcast. It's Three Plastic Surgeons and a Microphone, or Three Plastic Surgery Podcast. I'm Dr. Sal Pacella from San Diego and La Jolla, California. My Instagram handle is at San Diego Plastic Surgeon. We have Dr. Sam Rhee here joining us from Paramus, New Jersey. He's at Bergen Cosmetic. And we also have Dr. Sam Jajurikar from Dallas, Texas, at Dr. Sam Jajurikar. So, gentlemen, how are you this morning?
Doing well.
Doing great, Dr. Pacella. How are you?
Fantastic. We're all doing well. I got my coffee here first thing in the morning here. It's not as big as your cup there, Dr. Jajurikar.
No, and for all of our, well, my cup has already been drained, but yeah, it's bigger. But for all of our viewers who have watched a lot of these shows before, you'll know that a recurring theme in all of our shows is the quality of Dr. Pacella's internet, and we just wanted, I wanted to take this opportunity for about the first 20 to 30 seconds just to get sort of a state of the internet update from Dr. Pacella and why it looks like he's back in the 1980s. Dr. Pacella, let us know what's happening over there.
First of all, it's my own personal filter. It hides all the aging. Okay. Now, I've had some struggles with my internet connection, AT&T and whatnot. I've tried an internet extender. Not really working, jumping in and out. And then I think now that it's a little later in the morning, my kids are on their devices and stealing my bandwidth. I should just cut them off, I think. So thank you, Dr. Jajurikar. Well, let's move forward here. I just want to give our show disclaimer. This show is not a substitute for professional medical advice, diagnosis, or treatment. The show is for informational purposes only. Treatment and results may vary based on the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified healthcare professional with any questions that you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something in the show. And with that, I would like to hand it over to Dr. Jajurikar in Dallas to introduce our next podcast here.
Yeah, so for our viewers, we're always trying to brainstorm on topics that we haven't talked about before and things that patients find interesting. And one of the things that we all see a lot in our own practice are patients that are looking for alternatives to breast implants. There is sort of a growing movement out there for women who want to have natural augmentation, where they'll get breast augmentation with their own fat. And fat transfer to the breast is something that's still relatively new within plastic surgery. When I say relatively new, something over the last 10 or 15 years. I think today we're really fortunate to be joined by one of the busiest fat transfer surgeons in this region of the U.S. and possibly in the U.S. entirely, and that's John Burns. So a little bit about John Burns. John Burns is the practice president of Dallas Plastic Surgery Institute, which I happen to be one of the partners of. So I am biased by my personal friendship and personal relationship with him, but I also see the board where we operate every day, and the number of these cases that he's doing are truly astounding and truly more than probably the other 9 of us in the group times 10. So John is a graduate of Vanderbilt University. He ran track in the SEC. He actually has the mile record in the 1 mile at the high school that my kids still go to. I think it was 4:16 back when he was in high school, which I think at Vanderbilt he ran 4:03. You'll have to correct me when he's on. He's still an elite level runner, and he runs New York and Boston every year with his personal best time of 2 minutes and 45 seconds. Only plastic surgeon I know that actually has an endorsement deal with a shoe company. But beyond that, he's an incredibly talented surgeon. He is one of the nation's expert on lasers, and in the last 5 years has really become at the forefront of fat transfer to the breast. In addition to patients seeking primary breast augmentation with fat, he also has an expertise in patients that are getting what are called explants, or removal of their implants and fat transfer. So with that, let's bring on John.
Hey, Sam.
Welcome, John.
Thank you for the introduction. Yeah, the only thing I really care about is running. So thanks.
Yeah, I was telling these guys before you came on, the the story of when you had a sacral fracture, and I got an emergent. So John got an MRI that I ordered for when he was having some back pain. And I got an emergent call from a radiologist saying, your patient, John Burns, has multiple fractures of his sacrum, which for the viewers out there is the lower portion of the tailbone. He needs to be on strict bed rest. And I called him and he was running in a pool. He was like, no, it's fine. I'm just going to not run on regular ground. So.
Oh my gosh. Thank you, Sam. I really appreciate it. It's fun to be here. I think you guys have a great podcast, and it's been fun to watch you guys grow. So it's quite an honor for me. Thank you.
Well, thank you. So, the reason we brought John here today is to talk about fat transfer to the breast, which in all of our practices, it is something that we do, but it's probably not the number one, number two, or even one of the top 5 things that I'll see. In terms of your practice, how many women do you think you're seeing per week that are looking to have this done, fat transfer specifically to the breast?
Yeah, that's it's something that's really grown exponentially. I think that in this day and age, 2 factors have really driven, sort of an awareness of ALCL, which I think in the media has been a bit over exaggerated in terms of a risk factor, and the fact that I don't know many people doing textured implants right now. I think that I hope that we have a handle on that. The other thing being the concept of breast implant illness and where that is. I think it's a primarily internet-driven thing right now, but the science, I think, is lagging somewhat behind there. But in my practice, there's just a huge demand for non-implant based breast augmentation. I would say that I do as many breast implants as fat transfers. So it doesn't dominate my practice completely, but it's been an important part and a growing part of my practice, and something that I've enjoyed doing. And I think that as I've done more and more cases, I've learned more and more about the procedure and how to make it work for different types of women. So with that being said, I think I probably do between 100 and 200 cases a year, breast augmentation with fat transfer.
Yeah, I mean it's a remarkable number for sure. So one of the things that I always struggle with when someone is coming in and they're trying to inquire about breast augmentation utilizing their own tissue, what their expectations should be. Like let's say you're seeing a young woman or a relatively thin, fit woman who's, an A-cup breast, relatively flat chested. What's realistic? Like if she says, Dr. Burns, I want to be 2 cup sizes bigger with my own fat. Is that something that you can do?
I say this to the patients. I say, there's 2 methods of breast augmentation. One is implant based and one is fat transfer based. And I try to get a feel for their expectations and what they want. If they want a round, dynamic, impressive volume increase, they're probably not going to be happy with fat transfer. Implants, I tell patients, are reliable, they're reproducible. You have a 300 cc implant, you get a 300 cc result each and every time. The 2 things about fat transfer, number one is, the graft take. And I find it to be highly variable. It depends on the quality of the donor site fat. The problem is a lot of women who want fat transfer breast augmentation are rail thin. That's why they have small breasts. And so you have to be a really slick liposuction surgeon, in my opinion, not to give them contour irregularities. It's a very big struggle. And a lot of those patients I have to turn away because they're too thin. Not many, but some. And then the recipient tissue, if they have a nice solid B cup with good glandular tissue, I think that they're a much better candidate than those patients with a very tight skin envelope, a small A cup and very little breast tissue to graft into. I hear a lot of talk, hey, graft into the chest muscle. I don't do that. I just graft into the breast tissue itself. And I think the results, on a great case, I might get 2 cup sizes. On the very average case, I'll get 1. And if I'm kind of lucky, I'll get 1.5 cup size increase. It's a much different look too. I think patients need to understand they're not going to have a lot of upper pole fullness. They're not going to have a lot of cleavage. It's a way to augment their natural breasts. So you take what they have, you add a thick liquid, of which about 50 to 70% will take. And that's the result that they're going to get. one of the things I have to talk to patients about is, post fat graft, expectation.
So,
the first couple of days after surgery, they think you're awesome. I mean, they think, sorry, Sam.
No, I'm sorry.
You have fluid, you have fat, you have swelling, you have an amazing looking breast. I say, wait a month and then take a mental picture of yourself for the month. And then you'll lose about a third to a half of that over the next 6 months. And that's the realistic expectation.
John, why do you think there's such a push towards injecting fat into the muscle itself? What are your thoughts on that? What's the controversy?
I think it's better blood supply, probably. I think the muscle itself in most women is fairly thin, and I think you risk, puncture of the lung if you're really aggressive with it. This is a blind procedure. It's just like fat grafting to the butt. You think you're above the muscle, but who knows?
Mm-hmm.
So, two questions. One, there are a lot of surgeons out there that advocate pre-expansion of the breast before you do fat grafting. Their rationale is that the breast skin envelope is pretty tight, so they'll put patients in, special suction bras. For the viewers, like a Brava bra, something that's been used quite a bit. Do you do that for your patients?
I think it's probably a fair. I think it would help. I think, I spent some time with Tom Baker. I think that was his idea way back when. It's a really tough device to wear. It's uncomfortable. It's awkward. You really got to wear it, around the clock for a long period of time. It's very expensive and very hard to find. You just can't. I mean, I have patients on Amazon. They're trying to find it. I think, from a practical standpoint, I've had a lot of trouble finding these devices. So much so that I don't think it's practical to place patients in them. The other thing is just ease of use. I mean, you've got to do this for a significant period of time to get a stretching of the skin envelope and the muscle. So I don't use it in my practice very, very often unless a patient is motivated and they found one and they really want to do it.
And then what about multiple stages? Do you find that you have a lot of patients in your practice who you're doing repeated operations on to achieve their desired volume?
No, I'm probably different in that regard. I think probably at least half, if not 2/3 of my patients are from out of the state. They're flying in to see me. It's very expensive to come in, have surgery, and then go home. And I can't imagine them having to come back 3 and 4 times. I think your best shot is your first shot. I think once you've done the best you can do, with every subsequent operation, there's less and less, bang for your buck, so to speak. So the vascular bed is going to be the most robust, I think, in the first operation. As you place fat, the fat becomes, vascularized to a certain extent. It's probably not as vascularized as fat, or as the breast tissue, initially was. And so to ask a patient to come back 4, 5, 6 times, put it in 100 cc's in at a time, I don't think that's practical. Although, in a dream world, maybe that's better. At least in my practice, I would say my reoperation rate's probably around 5%. The other thing you have to think about is how much fat can they donate? Once you've given them your best shot, you're going to get 800 to probably 1,600 cc's of liposuction aspirate. Once you drain off the fluid, you have about 800 to use on most patients. They come back a second time. I don't think you're going to get that. You're going to get half that. So you're not going to get the same operation.
Yeah, no,
John,
for sure.
John, a question for you. In my practice, I do quite a bit of fat transfer for breast reconstruction after an implant exchange, say, and rippling over the top of the implant pre-pectoral. Right. Invariably I experience on occasion some issues with fat necrosis. I may have probably less than, maybe 20% of patients may develop some fat necrosis, and it's oftentimes a big concern with the oncologists and the primary care doctors. You obviously have a breast cancer patient. They present with a lump. I would usually order an ultrasound, and sort of determine that it's not a cancer lump. So I was just curious, your experience with fat necrosis, your workup after the fact. What do you tell patients?
Sure, it's a great question. Post mastectomy, fat grafting on top of implants, that's a great procedure. But you're right, fat necrosis is a real thing. It's a struggle for all of us, especially for a guy like me who does a lot of it. I used to use more concentrated fat to fat graft. One of the great things about being in practice with a big group is we watch each other work. And, one of the things I watch Sam has a massive fat transfer gluteal augmentation practice. And so some of the equipment Sam, brought to the practice and used, I've embraced for breast, one of those being the Wells Johnson system. And so it's a way to harvest fat, and then you can pull out this much fluid. And as I've done more and more, I've used a more dilute fat transfer product, so to speak. It goes in much easier. But I was using a more concentrated product, like, for example, the Evolve system. That fat's pretty concentrated. And if you don't exactly get it in the right spot, you over graft a certain area, I think you're going to get some fat necrosis there. It's too concentrated. It's too thick. And so I think when you have a more dilute fat, and you sort of overexpand the breast, once the fluid dissipates, you have a much more even distribution of fat. So that's helped me a lot. But I tell my patients, I said, you have to expect some level of fat necrosis. It's not 100%, absolutely, but I want to prepare them for that. And they have to understand going into the procedure that they very well may face, ultrasounds, MRI scans, and even biopsies to clear up the issue. I think it's very similar to the issue of capsular contracture with breast augmentation. I mean, it's an unfortunate side effect that we all face. And with fat necrosis, it certainly confuses the issue on screening. So if you have a patient that has a very strong family history and they're very reliant on screening, I don't think that's a good candidate for fat transfer.
Well, what I'd like to do is I'd like to share some before and after pictures, which I have from Dr. Burns's website, just to kind of talk about his approach. If I can find it, where is it? Okay. Are you seeing this right now or no?
Not yet.
Technical. Oh, there we go. No, I want to do that. Okay. Hopefully you can see Dr. Burns's before and afters. Can you see these? See this? Yes. Yeah. Okay. Perfect.
Yes.
Perfect. So, John, this is an example of a case that I got and was really impressed that I got from your website. That basically is showing a woman that's reasonably flat chested, doesn't appear to have any sort of previous history of implants at all, who clearly is thin, doesn't have a lot of fat excess on her. Had I seen this patient, I would have told her she was not a great candidate for a fat transfer, and I would have discussed doing a breast augmentation with an implant. But this is a really impressive result. This is almost a 2-cup size enhancement, if not more so, in this patient. Talk to us about what the breast feels like, how much volume you put in, how far post-op this is, and just sort of your approach to this case.
Yeah, so this is on the end of a spectrum, this would be a more difficult case. And so if I saw this patient today, I'd say you're a better candidate for an implant than fat. She was adamant that she did not want an implant. She was willing to accept, whatever result I could get for her. On thin patients, I think you have to do a technique called skimming, where you just basically liposuction on a deep plane level, so you're not near the skin, taking fat as best you can from the abdomen, the love handles, the back, the arms, circumferential thighs. And so with this particular case, I think I was able to get about 420 cc's. I looked it up last night, of graftable fat. Of that, there was some fluid in there. This is her 6-month result. I was pleased to get the take that I got. I don't think I could get this every single time, to be perfectly honest with you. But yeah, I mean, you know, you look at her lateral, you know, didn't have the upper pole fullness that you'd probably see with the breast implant, especially a higher profile implant. And I certainly don't think she has as much cleavage, but the skin on the lip was nice. You know, it held tight, and I think she's going to have and she was happy. So
yeah. This is
a great result.
Yeah, this is a fantastic, very natural result. What does this breast feel like? Does it feel soft and supple, or is this a big ball of fat necrosis?
You know, I think if it was a big ball of fat necrosis, you would definitely see dimpling of the skin. So it's going to feel like fat. It feels softer, I think, than a regular breast would probably feel. My best guess is she's probably got a few, you know, hard areas, almost like a fibrocystic, you know, sort of a thing, where some of the fat may have gotten hard. I can't remember exactly what hers, but a typically fat transferred breast is going to feel much, much different than an implant. You don't have the solid feel. You've got a more squishy, sort of a spongy feel to it.
Yeah. And then,
John,
yeah.
Sorry,
go
John, how long would it take for you to do a case like this versus a primary, just an implant?
Yeah. When I first started doing a lot of these, it took about 4 hours. I probably could do this case in about an hour and 20. It's quick. I think speed. I think it's. I don't want to say speed. I think efficiency is really important.
Yeah.
I think the longer the fat is out of the body, the worse your results. And I see a lot of guys, you know, 6-7 hours to do a fat grafting case, and I really wonder, you know, how much of that fat sitting at room temperature exposed to the air is really viable.
And
So,
for our viewers, how long is an average breast augmentation if you were to just use implants in a patient like this? How long?
Maybe 30 minutes, something like that.
yeah.
I think it can't be understated how you have to be good at liposuction in a thin patient like this, like Dr. Burns said, in order to get fat from all of these areas enough without causing issues, as you mentioned before. So that also is a skill that can't be understated.
It's really tough, and I think that the smaller cannulas, I've got, you know, I love the Wells Johnson. I don't mean to be a homer for those guys too much, but that they have a cannula that has no suction port on the backside, so you can turn the cannula so that you don't have the suction port facing the skin. And then I think, you know, multiple passes, but very, very deep, you know, on these patients. You know, it does hurt because you're close to the muscle, you know, you're not close to the skin. And I tell the patients, I say, hey, you have to be willing to accept a divot here or a divot there. You are so thin. I'm going to do the best I can, but post-operative lymphatic massage and dermology helps. I keep them in garments a little bit longer. So there's some things there too.
That's great.
Yeah, I mean, I think this is a remarkable result, and I couldn't agree more too of the need to go quickly to get that fat back in. I think that efficiency that you're showing contributes to how good your results are. So the next one, another case which I took from your website, real similar to the first one in terms of just a much more of a enhancement than I think I could have achieved in one stage. And what I'm really sort of drawn to this one is the upper pole fullness that you have in this patient as well. I mean, this looks, if you were to tell me that this was a moderate profile or moderate plus profile result, I would believe you. So how are you able to do this in a case like this?
The same goes for the other. I think on the lateral, you have a probably more upper pole fullness than I would typically expect. I think I grafted her. I think I put in. I tried to look last night. I think it was a 450 cc per side case. Occasionally, if the upper pole is not giving way, I'll use a pickle fork, and I'm able to expand a little bit better in the upper pole. I think you have to be careful doing that you don't create dead space, and then you graft into dead space. So Thank you for picking my best cases. We always like to show the best ones, but we rarely get to pick. So thank you for that. But I think that's a better than average result for me. Definitely.
Yeah, that.
I know that we talk about, diet after in terms of fat grafting, especially for Brazilian butt lifts. Do you do anything specific with them in terms of managing their diet afterwards?
I think long term, 5-10 years down the road, everybody has a physiologic set point. And I think we're all going to find our way back to that weight, whether we diet, exercise or not. I think the don'ts are more important than the do's. So I'm not real big on diet. I'm real big on no smoking, no diet pills, no, amphetamine based, things. There's weird things that people do too. One of the hot things in the explant world is infrared saunas. So I had several patients do that and lose considerable amount of fat doing these infrared saunas. I think they're like 140 degrees, and it's supposed to melt fat, and I'm sure it did. The other one is cryotherapy. And so a lot of these patients, for inflammation purposes, would go and get cryotherapy. I don't think that's good for a fat graft either, so quote unquote freeze the fat. There are some things that people do that I don't ask them to do. I think there's some people that believe in hyperbaric oxygen therapy post fat graft, and I think that's probably a waste of money. I don't know that would have a real significant impact. But those are the don'ts, and I just ask them to maintain a stable weight, and don't do anything stupid like do a fasting diet, for example, or a keto diet or something like that. I just tell them to enjoy their life.
I think those are all great bits of advice. I want to just, we're coming close to the end, but I do want to show a couple of explant cases because this is a common case that plastic surgeons will see now. Patient who comes in who has breast implants in place and either has symptoms of breast implant illness, a fear of breast implant illness, has something, capsular contracture, which to our viewers is basically pathologic scar tissue buildup around the implant. But the bottom line is they want their implants out. They don't want implants back in, and they want to have fat. And this is a difficult operation because one of the things you had mentioned before when you were talking about using a pickle fork is not creating dead space. And to our viewers, dead space is basically a large cavity that won't support fat if you're injecting fat into this area, and it can ball up and turn into fat necrosis. So I struggle with these cases quite a bit to get an adequate volume of fat into the patient. So talk to me about what's different about this case versus a primary breast augmentation, what steps you might take differently, the order in which you might you might inject fat versus taking out the implants, if you think it's important to take out the entire capsule. What's your basic philosophy to this sort of case?
Yeah. So I do a lot of these cases. You have women that come in and they have breast implants and they want their implants out. And I think one of the devastating consequences of an explant is what happens to the skin post-explant. And what typically happens is you have a paucity of tissue in the lower pole. The lower pole will tend to stick down. It's hard to get that muscle back to its original insertion point. They're usually subpectoral implants. And so you have a sort of a window shading effect. And then you have the breast without much tissue that will adhere to the chest wall. Once that process occurs, it's extremely difficult with the fat transfer to re-expand that skin envelope. And so I've developed sort of a technique for fat grafting immediately post-explant. And people think, there's a lot of different opinions on that. Most people, I think, would not fat graft immediately. But for me, the advantage is that you already have a skin envelope in the shape of a breast implant. So in my mind, what better time to create a beautiful breast than when the skin is in that shape? Because once it scars down, you have a really tough challenge ahead of you. And really the only way to do that is to, create dead space again, because you have to release that scar tissue. So in this case, most of these women also are going to want a capsulectomy with the operation. And so, explant capsulectomy first. What you're left with, I go ahead and close the incision. I try to recruit some tissue if possible to the lower pole. I typically will make sort of a more dilute fat transfer aspirate. So in these cases, what I'll do is I'll close first, and then I'll take a medial approach, and then I'll take the fat, and I'll thread it first through the subdermal plane. It does expand the tissue. It's very odd, but it's almost like a sponge. So as you expand the tissue, you can start grafting deeper and deeper into the breast, creating new spaces. And you can certainly feel, it's a very tactile operation, but you can feel when you've punched through and you're in that dead space where the implant used to be. So when you're in the wrong space, you take your foot off the pedal, because you certainly don't want to fat graft into the space where the implant was. I used to kind of loosely close the breast to, sort of use a 3-point Vicryl pop-off to sort of put the breast back onto the chest wall. But as I've done more and more cases, I'm just able to graft into the breast itself and expand the breast. Above the muscle, when you're in the upper pole, it's much easier because you have the pectoralis, you have the breast gland and the skin. So that's a much easier expansion. I think the challenge in these cases is really the lower pole.
Yeah, that's a really an interesting approach, and the results speak for themselves. Just one last case, real similar to the previous one. Just very impressed with the natural result and how much expansion of the lower pole you're actually getting.
John, I have another question for you.
Sure.
So do you have, so tell me about your experience with doing an explant, potentially doing a mastopexy and fat transfer at the same time. Challenges related to the skin flaps and, placement plane of the fat.
Yeah, that's a scary operation. And it's not necessarily always the fat transfer part that's the challenge. So you go explant, you do capsulectomy, you got a thin woman, you really worry about blood supply to the nipple. So I think the question is, where do you get your capsule out? So I do an inferior pedicle. I raise my flaps, basically between the subcutaneous fat and the breast, and then I basically split the pec. And so I leave the pectoralis muscle as much as I can attached to the breast itself, and then I sort of peel it back to expose the capsule, and then I take out the capsule. I used to do it where I kind of cheated on either side of an inferior pedicle, and I sort of went from inferior. But after several rounds of nitro paste on some patients, it was too much stress. I always repair the pec, once the capsule's out. But that's my approach now. So once you're closed, then I think that I either do a secondary fat transfer because there's just not much space in there, or if there is, I graft into the if I have a real solid blood supply. I mean, you can just look at the nipple and see if you feel like the blood supply is great. I'm very gentle, but I will graft into the pedicle, and then I'll graft into the upper flap. If I have a nipple that looks dusky or it's compromised in any way, I will not graft into the pedicle, and I'll just graft into the upper part of the flap. And I'm more conservative when I graft on a pexy than when I graft into a breast. So it's a scary operation. It's something I do not infrequently, but I go home, sweating a little bit on those cases. But that's a great question.
Yeah. I'll speak for the other two and say, really impressed with your results. And I've learned quite a bit from this, John. So thank you for taking some time out of your schedule this Sunday. and showing us these cases and kind of explaining your approach. Fat transfer of the breast is here to stay. It is a huge thing with patients, and I think we all have a lot to learn from you. So thank you for spending time with us this afternoon.
That was a lot of fun. Thanks, guys.
Yeah.
Appreciate it.
All right. Bye, everyone.
All right.
Have a
Take
great
care.
rest of the Sunday.
Sure.
Take care.